the pectoral girdle. The pectoral girdle consists of two bones, clavicle, scapula. These are joined to the axial skeleton at the sternoclavicular joint, each other at the acromioclavicular joint. The bones of the upper limb, scapula, extends from 2nd to 7th ribs posteriorly, when arm is by side. Spine, acromion and coracoid process are easily palpable. The glenoid fossa laterally contributes to the shoulder joint. Rotation of the scapula is required in full abduction of the limb. Strong muscular coverings protect the scapula and fracture is rare, requiring direct and severe violence. Clavicle. Medial 2/3 convex anteriorly and circular in cross-section. Lateral third convex posteriorly and flattened in cross-section. Articulates medially at the sternoclavicular joint, articular disc in joint. Attached to first costal cartilage by costoclavicular ligament. Articulates laterally with acromion at acromioclavicular joint, incomplete articular disc in joint. Attached to coracoid process by tough coracoclavicular ligament. It has no medullary cavity. It is the first bone to ossify in the fetus. It is the only long bone to develop in membrane. It may be pierced by the supraclavicular nerves. It transmits forces from the upper limb to the axial skeleton. It acts as a strut to hold the arm free from the trunk. It is the most commonly fractured bone in the body, the fracture usually occurring at the junction of the middle and outer thirds. Humerus. Head is third of a sphere and faces medially, upwards, and backwards. Head is separated from the greater and lesser tubercles by the anatomical neck. The tubercles are separated from one another by the bicipital groove, containing the tendon of the long head of the biceps. The upper end and shaft meet at the surgical neck, around which lies the axillary nerve and circumflex humeral vessels. The shaft is circular in section above and flattened, lower down. The spiral groove lies posteriorly on the shaft, and is related to the radial nerve, which winds round it between the medial and lateral head of triceps. The lower end bears the rounded capitulum laterally, for articulation with the radial head, and the trochlea, medially for articulation with the trochlear notch of the ulna. Medial and lateral epicondyles are extracapsular. The ulnar nerve lies in a groove on the posterior aspect of the medial epicondyle. Fractures of the humerus are common and important, in view of the close relationship of the axillary, radial, and ulnar nerves. Radius and ulna, considered together as they are complementary in the makeup of the forearm. Radius consists of head, neck, shaft and expanded distal end. Ulna consists of the olecranon, trochlear fossa, coronoid process with its radial notch, for articulation, with the radial head, shaft and small distal head, for articulation with the medial aspect of the distal radius. The carpus, figures 3.4 and 3.7, made up of 2 rows of 4 bones. Proximally, lateral to medial, scaphoid, lunate, triquetral, plus attached pisiform. Distally, lateral to medial, trapezium, trapezoid, capitate, hamate. Carpus is arched transversely, the palmar aspect being concave. Arch is maintained by individual bones, which are broader posteriorly than anteriorly, except the lunate. Arch is also maintained by the flexor retinaculum, passing from the scaphoid and trapezium laterally, to the pisiform and hook of the hamate medially. Metacarpals and phalanges. First, metacarpal is important because of the mobility of its carpometacarpal joint, which is responsible for opposition of the thumb. Second metacarpal articulates with 3 carpal bones, trapezium, trapezoid, and capitate. Capitate articulates with 3 metacarpals, second, third, and fourth. Joints of the upper limb, shoulder joint, figure 3.5, ball and socket joint. Articular surfaces, head of humerus with shallow, glenoid fossa of scapula, deepened somewhat by the labrum glenoidale, a cartilaginous ring. Capsule, lax and attached around epiphyseal line of glenoid and humeral head. Extends down to diaphysis on the medial aspect of the neck of the humerus. Capsule lined by synovial membrane along tendon of long head of biceps, which passes through joint. Synovium communicates with subcapsular bursa beneath tendon of subscapularis. Stability depends largely on strength of surrounding muscles. Rotator cuff, long head of biceps, deltoid, pectoralis major, latissimus dorsi, teres major, long head of biceps. Muscles acting on shoulder joint, abductors, supraspinatus, deltoid. Adductors, pectoralis major, latissimus dorsi. Flexors, anterior fibers of deltoid, pectoralis major, coracobrachialis. Extensors, latissimus dorsi, teres major, posterior. Fibers of deltoid. Medial rotators, pectoralis major, latissimus dorsi, teres major, subscapularis, anterior fibers of deltoid. Lateral rotators, infraspinatus, teres minor, posterior. Fibers of deltoid. The shoulder girdle. Movements of the shoulder joint itself cannot be separated from those of the shoulder girdle as a whole. Sternoclavicular joint, articular surfaces, medial end of clavicle and sternum, intra-articular disc. Ligaments, costoclavicular ligament passes from clavicle to first costal cartilage. This forms a fulcrum, so that when the outer end of the clavicle is raised, e.g. shrugging the shoulders, the medial end is depressed. Acromioclavicular joint, articular surfaces, lateral end of clavicle and the acromion, incomplete articular disc. Ligaments, coricoclavicular, conoid and trapezoid. Ligaments. Movements, induced passively by scapular movement. Dislocation of the outer end of the clavicle at the joint is easily reduced. Maintenance of reduction is difficult, owing to inclination of joint surfaces. Rotator cuff, sheath of tendons of short muscles of the shoulder, which surround and blend with all but the inferior aspect of the joint. Consists of supraspinatus, infraspinatus and teres minor, which are inserted from above down into the greater tuberosity of the humerus, and subscapularis, which is inserted into the lesser tuberosity. All the above muscles originate from the scapula. Supraspinatus is important in initiation of abduction of the shoulder joint. Supraspinatus passes over the apex of the shoulder, beneath the acromion and coracoacromial ligament, from which it is separated by the subacromial bursa. Movements of shoulder girdle, all but very slight glenohumeral movements are always accompanied by movements of the scapula, on the clavicle and of the clavicle on the manubrium. Abduction is initiated by supraspinatus, 15 degrees. Deltoid then abducts to 90 degrees. Further movement to 180 degrees is brought about by rotation of the scapula by trapezius and serratus, anterior. As soon as abduction commences at the shoulder joint, rotation of the scapula begins. Movements of the scapula occur with reciprocal movements of the sternoclavicular joint, i.e. elevate the shoulder and the joint is depressed, move the shoulder forwards and the joint moves backwards. The scapula can be elevated, shrugging the shoulders, and depressed. Trapezius and levator. Scapulae elevate, gravity, pectoralis major and pectoralis minor depress. The scapula can be protracted, moved forwards, round the chest wall, and retracted. Serratus anterior and pectoralis minor protract, rhomboids and middle fibers of trapezius retract. Rotation of the scapula upwards is carried out by trapezius and serratus anterior. Clinical points. In fractures of the clavicle, trapezius is unable to support the weight of the arm. The patient, therefore, supports the upper limb with the opposite hand. The lateral fragment is depressed and drawn medially by the shoulder adductors, and the broken ends overlap. Slight elevation of the medial fragment occurs due to sternocleidomastoid. Rupture of the tendon of supraspinatus results in inability to actively initiate abduction of the shoulder. The patient develops a trick movement of tilting the body to the injured side so gravity allows the limb to swing away from the trunk. Deltoid then comes into action. Supraspinatus tendinitis results in a painful arc of shoulder movement between 60 degrees and 120 degrees. It is during this range of movement that the tendon impinges against the overlying acromion and coracoacromial ligament. Serratus anterior, which protracts the scapula and keeps it applied to the chest wall, is supplied by the long thoracic nerve of Bell, C5, C6 and C7. Damage to this nerve, neck, breast or axillary surgery results in winging of the scapula. Elbow joint, figure 3.6, consists of 3 articulations and 1 synovial cavity. Humerulnar, trochlea of humerus and trochlear, notch of ulna, hinge joint. Humeroradial, capitulum and radial head, ball and socket joint. Proximal radioulnar, head of radius and radial notch of ulna, pivot joint. Capsule, thin and lax anteriorly and posteriorly, thickened at sides to form medial and lateral collateral ligaments. The lateral ligament is attached to annular ligament, which holds the head of the radius in place. The medial and lateral epicondyles are extracapsular. Movement, flexion and extension. Pronation and supination occur at proximal radioulnar joint with distal radioulnar joint. Muscles acting on joint are flexors, biceps, brachialis, brachioradialis, forearm flexors, extensors, triceps, and coneus, pronators, pronator teres, pronator quadratus, supinators, biceps, supinator. Wrist joint, figure 3.7, articular surfaces, distal radius and head of ulna, the latter separated from the carpus by an articular disc. Proximal articular surfaces of scaphoid, lunate, triquetral. Condyloid joint allows flexion, extension, adduction, abduction and circumduction. Movements are flexion, all muscles crossing the anterior aspect of the joint, extension, all muscles crossing the posterior aspect of the joint, adduction, flexor carpi ulnaris, extensor carpi ulnaris, abduction, flexor carpi radialis, extensor carpi radialis longus, abductor pollicis longus, extensor pollicis longus. Joints of the hand, carpometacarpal joint, thumb, saddle joint. Flexion, extension, abduction, adduction, opposition. Flexion/extension in plane parallel to palm. Abduction/adduction in plane at right angle to palm. Opposition, thumb opposes to little finger. Other carpometacarpal joints have limited gliding, movement only. Metacarpophalangeal joints, 60 degrees range of flexion/extension at metacarpophalangeal joint of thumb. 90 degrees at other metacarpophalangeal joints, together, with abduction, adduction, and circumduction. Abduction and adduction are impossible with the metacarpophalangeal joints flexed. Metacarpophalangeal joints of fingers, not thumb, are joined by deep transverse ligaments which prevent them spreading during a firm grip. Interphalangeal joints, hinge joints. Flexion/extension only. Collateral ligaments lax in extension and taut in flexion. Muscles controlling the hand, long flexors, flexor digitorum profundus, inserted into base of distal phalanx. Flexor digitorum superficialis, inserted into sides of middle phalanx. Profundus tendon pierces superficialis tendon over proximal phalanx. Profundus flexes the distal phalanx. Superficialis flexes the middle phalanx. Both muscles flex the fingers and the wrist. Long extensors. Extensor digitorum longus inserted into the extensor. Expansion. Extensor indicis inserted into the medial side of the extensor digitorum longus to index finger. Extensor digiti minimi inserted into the medial side of extensor digitorum longus to the little finger. They extend the fingers and wrist. Extensor expansion, figure 3.8, covers the dorsum of the proximal phalanx and sides of its base. Attaches by central slip into the base of middle phalanx and two lateral slips into the base of distal phalanx. Receives the insertion of the interossei and lumbricals. Small muscles of the hand, interossei, arise from the sides and front of metacarpals. Abduct and adduct the fingers. Insert into the extensor expansion. Flex the metacarpophalangeal joints. Extend the interphalangeal joints. Lumbricals arise from the four profundus tendons. Insert into the extensor expansion. Flex the metacarpophalangeal joints. Extend the interphalangeal joints. Muscles of the thumb, long muscles, flexor pollicis longus, inserted into distal phalanx. Extensor pollicis longus, inserted into the distal phalanx. Extensor pollicis brevis, inserted into proximal phalanx. Abductor pollicis longus, inserted into the first metacarpal. Short muscles, thenar eminence, adductor pollicis, inserted into base of proximal phalanx. Flexor pollicis brevis, inserted into base of proximal phalanx. Abductor pollicis brevis, inserted into base of proximal phalanx. Opponens pollicis, inserted along the first metacarpal. Muscles of the little finger, hypothenar eminence, abductor digiti minimi. Opponens digiti minimi. Flexor digiti minimi. Muscle actions. Flexor digitorum profundus flexes the distal phalanx. Flexor digitorum superficialis flexes the middle phalanx. Profundus and superficialis acting together flex the fingers and wrist. The interossei and lumbricals flex metacarpophalangeal joints and extend the interphalangeal joints. The interossei plus abductor digiti minimi abduct and adduct the fingers. Extensor digitorum has a weak abduction action. The long flexors have a weak adduction action. The abductor/adductor actions of extensor digitorum and the long flexors are eliminated by placing the hand flat on a table. Abduction/adduction then become the actions of the intrinsic muscles only. The above can be tested by gripping a card between the fingers, tests T1 and partly ulnar nerve integrity. Veins of the upper limb, important in cannulation. Important in creation of arteriovenous fistula for dialysis. Superficial veins, commence as dorsal venous network on dorsum of hand. Dorsal venous network drains into lateral cephalic vein and dorsal basilic vein. Cephalic vein lies subcutaneously just behind the radial styloid, where it is very constant in position. Runs up the anterior aspect of the forearm. Lies in groove along the lateral border of biceps in the upper arm. Passes to the deltopectoral triangle. Pierces the clavipectoral fascia to enter the axillary vein. Is superficial until it reaches the deltopectoral triangle. Basilic vein runs along the posteromedial aspect of the forearm. Passes to the anterior aspect of the elbow on the medial side. Runs in the groove along the medial border of biceps. Pierces the deep fascia at the middle of the upper arm. Joins venae comitantes of brachial artery, eventually forming the axillary vein. Veins at the elbow, variable pattern. Median cubital vein connects the cephalic and basilic vein. The veins are separated from the underlying brachial artery by the tough bicipital aponeurosis. Clinical points. The cephalic vein at the wrist is very constant and available for cannulation and for the formation of radiocephalic, Cimino breccia, fistulae for dialysis. The radial artery is in close proximity. Avoid injection of irritant drugs into the veins at the elbow. There is a risk of accidentally entering the brachial artery or a superficially placed aberrant ulnar artery. Drug addicts are not aware of these anatomical relations. Deep veins, venae comitantes, accompanying the arteries. Usually in pairs or multiple. Nuisance value when exposing deep arteries, to which they are closely applied. Arteries of the upper limb, figure 3.9, axillary, brachial, radial, ulnar. Axillary commences at the lateral border of the first rib as the continuation of the subclavian artery. Ends at the lower border of teres major to become the brachial artery. Divided into three parts by pectoralis major. First part gives off one branch, superior thoracic artery. Second part gives off two branches, acromiothoracic artery, lateral thoracic artery. Third part gives off three branches, subscapular artery, anterior circumflex humeral artery, posterior circumflex humeral artery. Relations: brachial plexus cords surround the artery, i.e. the lateral, medial and posterior cords. Brachial artery commences at the lower border of teres major as a continuation of the axillary artery. Terminates at the level of the neck of the radius, where it divides into the radial and ulnar artery. It lies immediately below the deep fascia in most of its course where it is readily accessible, e.g. for brachial embolectomy. It is crossed superficially from lateral to medial side by the median nerve at the level of midhumerus. High bifurcation of the artery is not unusual. Radial artery commences at the level of the radial neck lying on the tendon of biceps. Frequently bifurcation may be higher. Overlapped by brachioradialis in its upper half. In the distal forearm it lies between brachioradialis and flexor carpi radialis where it can be palpated at the wrist. It is closely related to the radial nerve in the middle of the forearm. Distal to the wrist the branches given off contribute to the superficial palmar arch. Passes deep to tendons of abductor pollicis longus and extensor pollicis brevis to enter the anatomical snuff box where it is palpable. Pierces first dorsal interosseous and adductor pollicis to contribute to deep palmar arch. Ulnar artery commences at level of neck of radius, frequently. Bifurcation may be higher. Passes deep to muscles from common flexor origin. Lies on flexor digitorum profundus, overlapped by flexor carpi ulnaris. Crossed superficially by the median nerve, separated from it by the deep head of pronator teres. Distally in the forearm it becomes superficial between the tendons of flexor carpi ulnaris and flexor digitorum profundus. Crosses in front of the flexor retinaculum to form the superficial palmar arch with the superficial branch plexus of the radial partly artery in the neck and partly in axilla. The ulnar nerve accompanies the artery on its medial follows. Side in the distal two-thirds of the forearm anterior and scalenus. The flexor retinaculum trunks in the posterior triangle of the neck. Divisions behind the clavicle. Cords in the axilla. Roots 5. Anterior primary rami of C5, 6, 7, 8, T1. Trunks 3. Upper C5, 6. Middle C7, lower C8, T1. Divisions 6. Each trunk divides into anterior and posterior divisions. Cords 3. Lateral, fused anterior divisions of upper and middle trunks. Medial, anterior division of lower trunk. Posterior, fusion of all three posterior divisions. Nerves, from the continuation of the cords. Musculocutaneous nerve, from the lateral cord. Ulnar nerve, from the medial cord. Radial nerve, from the posterior cord. Axillary nerve, from the posterior cord. Median nerve, from a cross-communication between lateral and medial cords. Branches of the brachial plexus. Roots. Nerve to rhomboids. Nerve to subclavius. Nerve to serratus anterior, long thoracic nerve of Bell, C5, 6, 7. Trunks. Suprascapular, upper trunk, supplies supraspinatus and infraspinatus. Cords. Lateral, musculocutaneous. Lateral pectoral. Lateral root of median. Medial, medial pectoral nerve. Medial cutaneous nerve of the arm and forearm. Ulnar nerve. Medial root of median. Posterior, thoracodorsal nerve to latissimus dorsi. Subscapular nerve. Axillary nerve. Radial nerve. The brachial plexus can be prefixed or postfixed on rare occasions. A prefixed plexus has a contribution from C4, a postfixed from T2. Axillary nerve, root value C5, 6. Arises from the posterior cord. Winds round surgical neck of the humerus. Accompanied by circumflex humeral arteries. Muscular branches to deltoid, teres minor. Cutaneous branch supplying sensation to the skin over the deltoid. Radial nerve, root value C5, 6, 7, 8, T1. Arises from the posterior cord. Lies initially behind the axillary artery. Passes posteriorly between the long and medial head of the triceps. Accompanied by profunda brachii artery. Lies in the spiral groove of the humerus. Pierces the lateral intermuscular septum at the lower third of the humerus and enters anterior compartment. Lies between brachialis and brachioradialis. Gives off posterior interosseous nerve at level of lateral epicondyle. Radial nerve continues as superficial branch to brachioradialis. Above wrist emerges posteriorly from under brachioradialis and supplies sensation by cutaneous. Branches to posterior aspect of radial 3 and a half digits. Main radial nerve supplies triceps and coneus, brachioradialis, extensor carpi radialis longus and part of brachialis. Posterior interosseous branch supplies supinator, abductor pollicis longus and all remaining extensor muscle. Cutaneous supply is to the back of the arm, the flexor and radial aspects of the dorsum of the hand. Musculocutaneous nerve, root value C5, 6, 7. Continuation of lateral cord of brachial plexus. Pierces coracobrachialis and runs between biceps and brachialis. Supplies biceps, brachialis and coracobrachialis. Innervates the skin of the lateral forearm. Median nerve, root value C6, 7, 8, T1. Arises from the joining of branches of the medial and the lateral cord of the plexus. Lies initially anterior to the third part of the axillary artery. Continues along the lateral aspect of the brachial artery. Crosses superficial, occasionally deep, to the brachial artery at midhumeral level to lie on the medial side of the brachial artery. Enters the forearm between the heads of pronator, teres. At this level it gives off the anterior interosseous branch. The median nerve then lies on the deep aspect of flexor digitorum superficialis. Superficial at the wrist lying to the ulnar side of flexor carpi radialis in the midline. Gives off palmar cutaneous branch at the wrist, which passes superficial to the flexor retinaculum, and supplies the palmar skin over the thenar eminence. It then passes deep to the flexor retinaculum, giving a branch to the thenar muscles beyond the distal skin crease. Supplies in its course all muscles of the flexor aspect of the forearm, except flexor carpi ulnaris and the ulnar half of flexor digitorum profundus, the muscles of the thenar eminence and the radial 2 lumbricals. Supplies sensation to the radial 3.5 digits and skin of the radial side of the palm. Ulnar nerve, root value C7, 8, T1. Formed by the medial cord of the plexus. Lies medial to the axillary and brachial artery 2, midhumerus. Pierces the medial intermuscular septum, descending, on the anterior surface of the triceps. Passes behind the medial epicondyle, where it is palpable. Descends between flexor carpi ulnaris and flexor digitorum profundus and then lies superficial on the radial side of the tendon of flexor carpi ulnaris. Accompanies ulnar artery in distal 2/3 of forearm, which lies to its radial side. Gives off a dorsal cutaneous branch 5 cm above the wrist, which is sensory to the dorsal aspect of the ulnar 1.5 fingers. Crosses the flexor retinaculum superficially. Supplies flexor carpi ulnaris, medial half of flexor digitorum profundus, hypothenar muscles, interossei, medial 2 lumbricals, adductor pollicis. Herbs, herb Duchenne, paralysis, force downward traction on arm during birth. Fall on side of head and shoulder, forcing the two apart. Root C5, C6 affected. Paralysis of deltoid, supraspinatus, infraspinatus, brachialis, biceps. Arm hangs limply by side, abductors paralyzed, with forearm pronated, brachialis and biceps flex and supinate, and palm facing backwards, waiter's tip position. Klump's paralysis. Upward traction on arm may damage T1, e.g. breech, delivery. Intrinsic muscles of hand paralyzed. Claw hand. Unopposed action of long flexors and long extensors. Extensors extend metacarpophalangeal joints. Flexors flex the interphalangeal joints. Use of the intrinsic muscles is lost, therefore, they cannot extend the interphalangeal joints, and hence clawing occurs owing to unopposed action of the long flexors. Associated area of numbness along inner and upper arm and forearm centered on elbow joint level. May be associated with Horner's syndrome due to traction on sympathetic chain. Wasting of small muscles of hand channels between metacarpals, wasting of first dorsal interosseous. Similar lesions may occur with Pankost's tumor or a cervical rib. Axillary nerve, damaged in fracture of surgical neck of humerus, or anterior dislocation of the shoulder joint. Deltoid paralyzed, therefore abduction lost. Small patch of anesthesia over the insertion of deltoid badge area. Radial nerve, damaged in fractures of midshaft of humerus, or compression of nerve against humerus when a drunk falls asleep with the arm over the back of a hard chair, trapping the nerve between the chair and the humerus, Saturday night palsy. Also pressure from crutch, but axillary weight-bearing crutches are rare nowadays. Posterior interosseous may be damaged in fractures or dislocations of the radial head or in the surgical approach to the radial head. Results in wrist drop if main nerve is damaged. Damage to posterior interosseous branch allows extension of the wrist due to extensor carpi radialis longus, which is supplied by the main radial nerve before the posterior interosseous branch is given off. Small area of anesthesia on the skin on dorsum of first web space. Median nerve, damaged in lacerations at the wrist and supracondylar fractures of the humerus. Damage at the elbow results in loss of forearm pronation, weakness of wrist flexion with ulnar deviation. Flexion depends on flexor carpi ulnaris and the medial half of flexor digitorum profundus. Loss of sensation on the lateral palm and radial 3.5 digits. Damage at wrist results in paralysis of the thenar muscles, except adductor, polysis, paralysis of radial 2 lumbricals, loss of sensation over radial 3.5 digits. Damage of the nerve at both sites causes loss of accurate opposition, and the loss of cutaneous innervation makes this a serious injury with loss of tactile response. Ulnar nerve, damage at medial epicondyle, e.g. fracture of the medial epicondyle or dislocations of the elbow, lacerations at wrist. Damage at the wrist results in clawing of the hand similar to Klumpke's paralysis, except less clawing in second and third digits because of median nerve supply to lumbricals, which is intact. Sensory loss over medial 1.5 fingers. Damage at the elbow results in similar lesion to wrist except less clawing in fourth and fifth fingers, as flexor digitorum profundus to those fingers is paralyzed. Flexor carpi ulnaris is paralyzed, therefore a tendency to radial deviation at the wrist. Damage to ulnar nerve leaves a remarkably efficient hand. Confirmation of the diagnosis is by testing for lack of sensation of the medial 1.5 digits and loss of abduction and adduction of the fingers with the hand flat on a table, excludes trick movements of long flexors and extensors. The breast. The female breast is made up of fat, fibrous tissue, glandular tissue. Fat predominates in the non-lactating breast. Contains 15 to 20 lobules of glandular tissue. Lobules separated by fibrous septa running from the subcutaneous tissues to the fascia of the chest wall, the ligaments of Astley-Cooper. Each gland drains into a lactiferous duct, which converges towards the nipple, and each becomes dilated to form a lactiferous sinus beneath the areola. The areola is lubricated by the glands of Montgomery, large modified sebaceous glands. Blood supply. the axillary artery via lateral thoracic and acromiothoracic branches. The internal mammary, thoracic, artery via its perforating branches. From the intercostal arteries via the lateral perforating branches. Venous drainage is to the corresponding veins. Lymphatic drainage, along tributaries of the axillary vessels to the axillary lymph nodes. Along tributaries of the internal mammary vessels, to the internal mammary chain. Although there is free communication between the lymphatic vessels lying between the lobules of the breast, there is a tendency for the lateral part of the breast to drain towards the axilla and the medial part to drain to the internal mammary chain. Anatomical classification. Axillary nodes are arranged into 5 groups. Anterior, lying along the inferolateral border of pectoralis major related to the lateral thoracic artery. Posterior, lying along the subscapular vessels. Lateral, lying along the axillary vein. Central, lying in the axillary fat. Apical, lying immediately behind the clavicle, at the apex of the axilla superior to pectoralis minor. Surgical classification. Level 1 nodes, lying inferior to the inferolateral border of pectoralis minor, usually comprising the lateral, anterior and posterior nodes. Level 2 nodes, consisting of those nodes posterior to pectoralis minor, comprising the central nodes, and some of the apical nodes. Level 3 nodes, consisting of those nodes beyond the superior border of pectoralis minor, comprising the apical nodes and the infraclavicular nodes. Male breast, rudimentary. Small, primitive ducts may be present, supported by fibrous tissue and fat. Carcinoma may occur. Clinical points. When spread of a carcinoma of the breast has infiltrated normal pathways of lymphatic drainage, it may spread by other routes to lymphatics of the opposite breast, contralateral axillary lymph nodes, inguinal lymph nodes, cervical lymph nodes. Incisions in the breast are made radially, to avoid cutting across the line of the ducts. A blocked duct may become dilated during lactation, to form a galactocele. Glands of Montgomery become enlarged in pregnancy, to form Montgomery's tubercles. Dimpling of the skin over a carcinoma of the breast is the result of malignant infiltration and contraction of Cooper's ligaments. The nipple may fail to evert, and it is important to know if this has been present since birth or is a recent event, as the latter may indicate carcinoma or ductictasia. Supernumerary nipples may be present along the milk line of mammary gland of primitive mammals. Lymphatics of the upper limb, superficial and deep lymphatics. Superficial lymphatics accompany the veins and the deep lymphatics accompany the arteries. Few superficial lymph nodes in the upper limbs, chiefly the epitrochlear nodes. Efferents from epitrochlear nodes pierce the deep fascia and end in the axillary nodes. Axillary lymph nodes drain the following: the breast, the pectoral region, the upper abdominal wall down to the umbilicus, the skin of the back down to the iliac crest, the upper limb. Arranged in 5 groups, although these are not distinct, lying deep to pectoralis major along the lower border of pectoralis minor, posterior, along the subscapular vessels, lateral, along the axillary vein, central, in the axillary fat, apical, immediately behind the clavicle at the apex of the axilla above pectoralis minor, and arranged along the axillary vein. All other axillary nodes drain through this group. From these nodes, the subclavian lymph trunk emerges. Surgical anatomy of the axillary lymph nodes is important in relation to breast surgery. From this point of view, they are classified into 3 levels. Level 1 nodes, present below and lateral to the inferolateral border of pectoralis minor. Level 2 nodes, behind pectoralis minor. Level 3 nodes, above the upper border of pectoralis minor. Specialized areas of the arm. Axilla. The axilla is a pyramidal space through which structures from the head, neck, and thorax pass into the arm, and structures from the arm pass into the thorax. Being pyramidal, it has a base, 4 walls, and an apex. Base, skin and fascia of the armpit. Medial wall, rib cage covered by serratus. Anterior. Lateral wall, bicipital groove of the humerus. Anterior wall, pectoralis major and pectoralis minor. Posterior wall, latissimus dorsi, teres major and, more superiorly, subscapularis. Apex is bounded anteriorly by the clavicle, first rib, medially, and the acromion and superior border of the scapula posteriorly. Contents: brachial plexus, axillary artery, axillary vein, lymph nodes, fat. Antecubital fossa, bounded by pronator teres medially and brachioradialis laterally. Its floor is formed by brachialis and supinator. The roof is formed by skin, superficial fascia, and deep fascia augmented by the bicipital aponeurosis. Contents include the brachial artery and medial to it the median nerve. Carpal tunnel. The flexor retinaculum forms the roof of a tunnel, the floor and walls of which are formed by the concavity of the carpal bones. Within this tunnel are the tendons of flexor digitorum, superficialis, flexor digitorum profundus, flexor pollicis longus, and flexor carpi radialis. The latter tendon is in its own separate osteofascial compartment. The most important structure to pass through the tunnel is the median nerve. Any lesion diminishing the size of the tunnel may result in compression of the median nerve, carpal tunnel syndrome. The superficial palmar branch of the nerve is given off proximal to the flexor retinaculum, and therefore, there is no sensory impairment on the lateral side of the palm if the nerve is compressed in the carpal tunnel. Anatomical snuff box. Medial border formed by tendon of extensor pollicis longus. Lateral border by the tendons of abductor pollicis longus and extensor pollicis brevis. Contents include the base of the metacarpal of the thumb, the trapezium, the scaphoid, the radial styloid, and the dorsal branch of the radial artery. Important clinically, as tenderness can be felt in the anatomical snuff box with fractures of the scaphoid. Dorsal branch of the radial artery lies close to the cephalic vein, and therefore this is an appropriate site for creating arteriovenous fistulae for dialysis. Pulp spaces of fingers. Pulp space is fat packed between fibrous septa, from skin to periosteum. Blood vessels have to pass through the space, except the proximal branch to the base of the distal phalanx. Pulp space infection increases the pressure in the space. This may result in arterial thrombosis and necrosis of distal phalanx, with the exception of its base, which is spared because of the proximal branch. Bursae of the hand and synovial tendon sheaths. Flexor tendons traverse a fibroosseous tunnel for each digit. The fibrous sheaths end at insertion of flexor digitorum profundus. The fibrous sheaths are lined by synovial membrane. Second, third, and fourth fingers have synovial sheaths that close proximally at the metacarpal head. Synovial sheaths of thumb and little finger extend proximally into the palm. Synovial sheath of long flexor of the thumb extends through the palm deep to the flexor retinaculum to 2.5 centimeters proximal to wrist, radial bursa. Synovial sheath of fifth finger forms the ulnar bursa, which encloses all finger tendons in the palm and extends proximally deep to the flexor retinaculum, for 2.5 centimeters above the wrist. The radial and ulnar bursae may communicate. Infection of the synovial sheath to second, third, and fourth digits is confined to the finger. However, infection of the first and fifth sheaths may spread into the palm or from one bursa to another. Palmar spaces. Mid-palmar space, behind the flexor tendons and ulnar bursa. In front of the third, fourth, and fifth metacarpals. First and second metacarpals are cut off by adductor pollicis, which arises from the shaft of third metacarpal. Thenar space, superficial to second and third metacarpals and adductor pollicis. Separated from mid-palmar space by fibrous partition. Infection in spaces is usually from a direct penetrating injury or neglected tendon sheath infection. Infection rare in spaces due to antibiotics. Palmar infections may result in marked dorsal edema. This is caused by the thick palmar skin being firmly bound down to the underlying palmar aponeurosis. In contrast, the skin of the dorsum of the hand is loose, and fluid can readily collect deep to it. Palmar aponeurosis, part of the deep fascia of the hand. Blends with the fibrous flexor sheath of the fingers. Attached to sides of proximal and middle phalanges. Dupuytren's contracture results in thickening and contraction of the palmar fascia with flexion of the metacarpophalangeal joints and proximal interphalangeal joints. The distal interphalangeal joint is not involved.